we have two phenomenal orthopedic surgeons. Dr. Feierabend is one of them. Dr. Feierabend, Dr. Sig as we call him, he graduated from the University of North Dakota first in the mechanical degree, then went on for his medical degree. He did complete his residency at Michigan, has been providing orthopedic treatment, especially in the areas of adult reconstruction and general orthopedics. He's a member of the American Academy of Orthopedic Surgeons and the American Medical Association. Dr. Feierabend is board certified by the American Board of Orthopedic Surgery. He is a pleasure to work with, loves to fish, and he loves MS pizza so much so that every single day he is here in Florida, goes to MS pizza. I don't think we've missed one, but I heard.
Maybe one.
Maybe one.
In a year.
We will have time for questions at the end, do that along the way. But if needed, we might need, excuse me, might need to stop at about 1:15 as today. If there's anybody that's interested in appointments at the end, happy to go all the way up to the front clinic. We will have some scheduled staff afterwards as well. So look for that. We also have a table for straight as well. That's a plan. We got here today too. And if anybody that is online, we want to make sure that you're muted as well, so there's not feedback from group leaders in the building as well. Otherwise, I will turn it on over to Dr. Feierabend. Thank you.
Good afternoon. So yes, it's a great turnout. Thank you guys all for coming. So I kind of divided this presentation why you need joint replacement, kind of arthritis talk first, and then about the technology that's here and more with the robots and striker reps that set this all up here. This is essentially the latest in joint replacement, how to get a very accurate result while getting certain good feedback about how they're doing and how the cases are progressing. Can you hear me okay? Work. Can you hear work? I don't know if I can go any louder than that for longer than an hour. Oh, okay. I'll try to be a little, can you turn the dial just a smidge? Okay. All right. So in Laura here though, I think I have a, let's see how we get this thing started. I need to start here somewhere.
Point it back there.
Back there.
Yep, let's try that.
Got another, or can I use the mouse to click it?
You can, if you want to close that recording started.
At 90 degrees to it?
Yep.
And right-handed.
There we go.
Nothing. Oh, it's one again.
Okay, now try your clicker.
The latest in technology here, and we're struggling.
I'll try it for you.
Okay. I think it looks like it's on the phone call part. It's not the presentation part.
All right, try clicking one more time. There it is.
Yes, there we go. I like my introduction there. I usually just go by Sig or Dr. Sig, whatever. Siegfried's too hard. Feierabend's a long last name, and if you put them both together, it's like 19 letters. I think it was 3rd grade before I got that one right. And again, here in Moore, though, it's a great place to work. There's a great hospital. Your community has worked really hard to put together a great facility here and to provide things like this robotic knee replacement. It's a big investment, and it's the latest technology you could get anywhere. If you want to get a good joint done, you can have it done right here in Moore with the latest technology. We have great staff here, good OR staff, good clinic staff. Everybody here is just a great person to work with. Okay, a little bit about hip and knees. Again, great town. Your hospital is beautiful. It's nice always to drive into town and see it there. It's a nice little highlight to your town, along with Emma's Pizza. Fantastic. You need this dually crust cheese in the middle. That's a picture of me. So what is osteoarthritis and why you need a joint replacement or want to discuss the joint replacement? Osteoarthritis is the most common form of degenerative joint disease. It's usually considered a wear and tear. It kind of develops as we get older. The cartilage kind of falls apart on the end of our joints, and then it starts to cause pain, deformity, loss of motion. The best thing you can do to avoid arthritis is pick good parents. There seems to be a really good genetic component to that. So if your parents have bad hips, knees, you're kind of headed that direction too. Symptoms, most of us have had arthritis from an injury or something, especially after you get over in your 50s and older. The joints feel warm, they feel stiff, they start to get crooked. A lot of times you'll notice people are walking bow-legged, or they have loss of motion, difficulty getting into or out of a car, in and out of a booth, that type of thing, where the joint just doesn't move like it should. A lot of times you'll see it on fingers, they start to go crookedy, and then they just start to ache. Here's a normal knee. So there's an x-ray. This is what we look at first when we're in the office. This is kind of an orthopedic diagnostic picture is x-rays. They tell us a lot. You can see the health of the bone, how it looks, the density of the bone, how the bones are aligned, and how everything's tracking. So this is a very nice looking knee. Labeled that up for you. The top one is your thigh bone and your femur. The bottom one is your tibia. Where they rub together is the knee joint. And then there's a little cloud floating in there. You can kind of see it hanging around right here. My laser pointer is as lame as they come. Okay, little cloud up in here. That's the kneecap, and that attaches to your quad or your big muscle in the front of your thigh and allows you to extend your knee. All three of those bones are covered with cartilage when they touch, and that's a slippery, smooth surface. Here's a picture of a knee scope. So not all things need replacement, unlike these striker reps will tell you. Sometimes we can fix things with just a little scope or something else to the knee. This is a normal compartment up here. You can see that beautiful cue ball up here, nice and smooth. That's beautiful, healthy cartilage. That little sharp edge thing right on the edge here, this is a meniscus. So if you've ever heard of a meniscus tear, that's what that is. That nice, beautiful sharp edge. That's a totally normal looking knee. And then the top of the shin bone is also covered with a very slippery surface. So this looks great right there. Then I got another picture here. This is what happens when you get arthritis. The cartilage falls off the bone and kind of wears through. Cartilage has no nerves, it has no blood vessels, and it doesn't really heal. So as it wears out, your body can't make more. You only get one set of cartilage for your whole life. When we do a knee scope of this, you can see how this looks beautiful and smooth, and that the yellowy orangey stuff, that's actually bone exposed. If you've ever broken a bone, you know that bones have lots of nerves in them, and when you rub two bone ends together, they hurt, and that's the pain of arthritis. The hip joint, there's a picture right here, is made up of the pelvis, or the part of you that your hips are on, or the big bones that stick out that your belt sits on. That's your pelvis, and it's got a socket in it. The hip joint is a ball and socket joint. It's a nice round ball, and it goes in a nice round socket, and it has a lot of motion. It flexes, extends, and rotates, and it's a very nice joint until it goes bad. Here's a hip scope, which is also a surgery that can be done to take care of small pathology within the hip. And again, if you look at the top of that ball, it's beautiful white cartilage, smooth, and it looks like that's the top of a cue ball or the moon or something like that. It's just nice, smooth white cartilage. If you ever heard of hip labral tears, this little kind of curtain thing on the back, that's the labrum that keeps the fluid in the hip to allow it to move real nice and smooth. Here's a picture of a hip that has been taken out for hip arthritis. And if you look at that ball, those two don't look anything the same. As the ball wears out and the socket wears out, it loses its roundness. So now you have an egg-shaped ball and a funny-shaped hole. And when you force that hip to move, it hurts. Hurts right in the groin area where the leg comes together with the body, hurts right in there. And this is why. That's all exposed bone covered with nerves, and it just hurts. The body also has fluid pressure in there, which forces fluid into the bone, which makes the cysts and those little pock marks. And so people with hip arthritis know they hurt. Try again. Maybe the arrow work. Yeah, well, I'm stuck again. There we go. Is that the correct one? Yes, good. So how do you know if you have arthritis or if you have something else wrong? The most common thing that people think of when they have hip pain is, I have a bad hip, or I have arthritis, or there's something wrong in my hip. I always ask people when they come to see me, where is your hip? And I get anything from here to here to here to in my butt. And those are all different things. So that's why you need to see your doctor and have like an examination to figure out, is it actually your hip? If you have a pinched nerve in your back, it can feel like it's your hip. It can feel like it's your knee. It can feel like it's your foot. So what I tell people too is when they come in, if the light is off in the room, it could be the switch, it could be the wire, it could be the light bulb. So that's where your exam comes in to figure out what is causing the pain in your hip. X-rays again, X-rays are where we start out first. We get that picture of the hip that shows us a lot. It only shows us the bones, but with their positioning and how they look, we can get a lot of information about what's going on with the joint. On the left side there, you have an X-ray of the hip, of a normal hip. It's got normal joint space. It's got a nice round ball to it. And the bone all kind of has the same shade to it because it's all about the same density. On the right side, that is a bad hip or an arthritic hip. You don't see any joint space. There's bone spurs that are growing on the ball right here and some bone spurs at the bottom. No joint space, and the body is actually reacting to the stress and making the bone harder, which is where all that bright white is coming from. The body is trying to make that bone as hard as possible so it doesn't keep wearing through. So when we take them out, sometimes they look like polished marble even just because it's so hard. And you can see that on the X-ray with that bright white. Just all your body just trying to hold that thing together so it doesn't fall apart. Here's back to that knee X-ray again. Nice, normal joint space, good, same consistency across the bone. I can't see that there's cartilage in here because I don't see anything in there, but that's what's in between is cartilage and meniscus. These are normal looking knees, and it probably has none or very minimal arthritis like that. Here's an X-ray of a bad knee, and the first thing you can see is again that bone on the insides of the knees. There's no space. You can see the little bone spurs that are growing on the edges here, and you can also tell that the bone is getting harder again to try to protect itself because it doesn't have that smooth, soft layer of cartilage. Back to the normal one again. So you can see the difference just on an X-ray. We can tell a lot about what state of the knees are in. Always the first thing we try for arthritis is non-operative treatments. There's a ton of things we can do. Weight loss, physical therapy, injections, anti-inflammatories, supplements, canes, icing it, eating it, having a cold beer, whatever it takes. There's a lot of things we can do. People usually handle a certain amount of pain and they modify their activities to keep the pain to that level that they can handle. So if you walked 5 miles 5 years ago and now you only walk 1 mile, the knee doesn't hurt any worse, but you're limiting your life because of it. Oh, somebody's here. Can you let them in? Oh. So here's some of the non-operative treatments that are very common, like the supplements, like the fish oil, the turmeric. There's other types of natural anti-inflammatories that people do take that do help with arthritis, pain, and discomfort and swelling. There's the more common stuff that you see doctors recommend, the anti-inflammatories, ibuprofen, naproxen, Celebrex, meloxicam, or cortisone injections or gel injections. What these do, anti-inflammatories, inflammation is what's causing pain in the arthritic joint. So when your bones start to touch, they actually make bone dust as they're wearing, and that like sawdust floats around inside the knee. The cells inside the knee eat that up because they say it's not supposed to be there, and then they say something's wrong. What they do is they make inflammatory things, they call them like cytokines or inflammatory markers, and that's what makes the knee hot. It makes it swell. They dump fluid on the knee, the cells, and try to make it lubricate because they say something's wrong with it. And that's what gives you the symptoms of arthritis is that inflammation. These bottom three here, the steroid injections, the anti-inflammatories literally calm down that inflammation so your body doesn't get the fluid in the knee, the heat on the knee, and the achiness in the knee. The gel injections, they did studies on young people, and they found out that young people have more of a protein called hyaluronic acid, which is kind of like a big ball-bearing molecule that holds a lot of fluid and helps create that fluid film between the two joints or the two articular surfaces they roll, like oil viscosity. They found that if they replace that in some people by giving them that injection, it can help that knee move more smoothly, less bone dust, less inflammation. If you've heard of that shot, there's Synvisc is one brand, but there's a bunch of them. It's hyaluronic acid. A lot of people have heard it called like the chicken shot or the rooster comb shot or the gel shot or lube shot. But that's what it is a big ball bearing molecule. Oh, one other thing on this one. Glucosamine, chondroitin, those type of things, those other supplements, the only recommendation I have is that if you're going to try one, pick one and change one thing at a time. Don't say, I'm going to lose weight, take ibuprofen every day and take glucosamine and give all the credit to the glucosamine. Just add the glucosamine and try that. And the other thing is there is no regulation on supplements. So if you're going to buy a supplement, get it from Sam's Club, Costco, Target, Walmart, somewhere where they independently verify that it actually has glucosamine in it. Because I could sell you all Tic Tacs and tell you whatever it is that I want, and there's nobody that verifies it. But those bigger stores, they do verify it actually has glucosamine, chondroitin in it, and at the level that they say. Kind of talked about these already. Again, the physical therapy, staying active. Every time I do one of these talks, there's always somebody in the audience who is 90+ years old that says motion is lotion. You got to keep those joints moving. If you sit still, you get stiff, things don't move, so keep it moving. So when do we talk about replacing the joints? Again, once those non-operative things stop working. Usually injections work for a period of time. The first one is usually the best. Some people get a year, 9 months relief, 2 years of relief with the Visco or with the cortisone injections. The next one tends to be a little bit less and less and less, and at some point they stop working. Then we try other options, and at some point we say, all right, it's time for a joint replacement. That's your option, or live with it. So joint replacement is what we consider an elective surgery. You never have to have a joint replaced. There's no one that can tell you you have to have it replaced. That's a personal decision. It's to help make your life better and more productive, but it is not a necessary, it's an elective replacement. Benefits of it, again, are getting you more active, straightening out your joints, allowing you to walk further with less discomfort, and having more range of motion. With hip replacements, easier in and out of a booth at a restaurant, easier in and out of your car, up and down stairs, moving that foot around, getting your shoes on, tying your shoelaces. Knee replacements, more that deformity of the knee or ability to walk. If you sit too long, this achiness, that's where that knee replacement comes in. Can drastically improve the quality of life. Linda Hopp, hi. Joint replacement, also called arthroplasty is what we call it. If you ever heard of total knee arthroplasty or total hip arthroplasty or total joint, that means the same thing as replacement. And essentially what we're doing is we're taking an arthritic joint, straightening it out, removing the bone spurs and the hard bone, and recapping the end of the bone with something that's smooth and has a very good wear properties and allows that joint to move like it's supposed to. Here's a picture of a hip replacement. If you came in through there and looked at that, they got some hip replacements back there and knee replacements. You can kind of pick them up and feel what they feel like. They're made out of metal. They're highly polished or ceramic. So here's a hip right here. This is the most common type of bearing that we use. It has a ceramic ball with a beautiful pink color. It is very, very cool to look at, actually. Do you have one back there, Joe, too? Yeah, so if you pick one up to it, it's kind of cool. They're really heavy and they're very, very smooth. There's multiple bearing surfaces that can be out there. So if you've heard talks before, there's metal on metal, there's metal on plastic, there's ceramic on ceramic, there's ceramic on plastic. Ceramic on plastic seems to be the best. It has a great wear rate. The best wear rate is ceramic on ceramic. But with ceramic on plastic, we're talking about 1/100 of a millimeter or less per year. So with a normal hip replacement, 4 to 5 millimeters of that smooth, high molecular weight polyethylene, it's well over a lifetime worth of wear on that. The problem with ceramic on ceramic was that some people squeaked and some people broke them. So that was a problem with those. So this is a very, very good wear surface. The ceramic balls don't break anymore like 20, 25 years ago. It's a great implant. We use special types of materials. If you look at this thing, it's got a cool coating on it. If you go back there, you can feel that too. It's a special coating that your body likes. It thinks it's a broken bone, grabs onto it, and that implant after about 6 to 8 weeks becomes part of you and stays with you, okay? How we put them in is that we put them in a press fit, which is like pounding a nail into a piece of wood. We make a hole that's a little too small, force that implant in there so it's got tension of the bone holding it in place. That's what holds you initially. That's why we tell you to be careful, use your walker. After about 6 weeks, that thing's part of you and it doesn't come loose. Total knee replacement. Same idea there. We're recapping the end of the thigh bone and the top of the shin bone and the back of the kneecap cap in a lot of cases with a smooth surface. That's that same high molecular polyethylene or very smooth plastic. If you've ever snowmobiled, it's kind of that same stuff they make the high packs out of that your track runs on. Very good wear property. They think they do a little bit more technology than that, but I think Skidoo does pretty good too. It's a good slippery surface on a very smooth metal with the synovial fluid. Good longevity to that. Potential complications, nothing comes without some risk to it. This is why this is elective surgery. Things do happen. There are always risks. Risks of anesthesia, risk of infection, risk of blood clots, and we do everything we can to help prevent these, but they are still risks. The risk of something bad happening is less than 1%. We do everything we can. We give you antibiotics beforehand. We give you antibiotics afterwards. We all wear spacesuits. They have all that latest technology here and more with the latest infection prevention, laminar airflow, all that stuff. The implants are single use. They're peel packed. They come sterilized from the factory. We only open them once during your surgery. So everything we can to help prevent infection, which is a bad complication. And then blood clots. So we do put you on a blood thinner. We make sure that you're moving your toes. We put squeezer things on your legs to help keep that blood flowing during surgery. And we keep our surgery times down. And all those things help prevent blood clots as well. Loosening and premature wear, again, with the better materials, less likely, but they can happen. Most infections, though, or pardon, most loosening now is related to infection, but again, less than 1%. I do always put a little bit of a talk about hip replacement as well. We also do minimally invasive direct anterior hip replacements here. Dr. Helene and myself both do the minimally invasive direct anterior. It is an excellent hip approach. It's muscle sparing, as in we split between the muscles to replace the hip, as opposed to the traditional method of peeling the muscles off the bone, replacing the hip, and then reattaching those muscles to the bone with drill holes or heavy sutures to do it. The first 6 weeks of recovery after direct anterior hip replacement are quicker. And after that, they're about the same. But those first 6 weeks are important, and they do go quicker with this if you're a candidate for a direct anterior hip replacement or a minimally invasive one. And Dr. Holy and myself have done hundreds each, thousands each, probably. I've been doing this since 2016, so I'm probably close to that number there. Lots of hip replacements. This is kind of an interesting slide. I don't know how people normally take this, but if you ever have looked at a piece of steak, there's little parts of the muscle with a little white layer in between called fascia in between the muscle. And that's how we do this direct anterior hip replacement. So if you look at that little red line, these are a slice of the leg. And each one of these is a separate muscle with its own blood supply and its own nerve supply. With the hip replacement, we kind of sneak through these fascial layers, sparing the muscle, not peeling it off the bone, not cutting it, and replace the hip deep to it. The muscle then closes over the top and it's still attached and it's still working, okay? You don't have to wait for that muscle to heal back down to the bone. Here's just some chart of kind of the benefits of the hip replacement. Again, those first 6 weeks, the post-op pain, getting up and going, getting rid of your walking aids, cane, walker, etc. Most people after a hip replacement come to their 1 month visit with no walking devices, and most of them are feeling pretty dang good by that point. After 6 weeks again, though, the results are the same no matter how you had it done. The most common reason people are not candidates for minimally invasive hip approaches are usually due to size. If we can't safely replace the hip through a small, it's about a 4 to 5 inch incision, then we usually have to go from the side where we have more exposure for it. So it's mostly due to patient size that would restrict a anterior hip or minimally invasive. So again, to avoid those complications, we do everything we can. Laura here does a great job with your pre-ops and everything else too, making sure that everything is taken care of. Get your heart checked, your lungs checked, kidneys checked, sugars, all the rest of that, and see your primary care beforehand to make sure that everything is minimized as much as possible. And then make sure that our surgical flow goes nice and smooth and you have a good experience. Last part about joint replacement for this first talk is expectations. That's why people are occasionally disappointed with hip replacements. Obviously, complications happen. That is a disappointing thing. It is something that we have to deal with. We do everything we can to manage those. The biggest thing though is that people expect a lot of times that a joint replacement will be as good as the joint that they had 20 years ago or before it was injured. You will never have anything better than you started with. The joint you have that God gave you is the best joint you're ever going to have. This is a good alternative to a painful joint, but it's not perfect. So realistically, 90% of people report that they're doing better. They have better motion. They have better mobility. They have decreased pain. 9 out of 10 joints or 90% last at least 20 years. And people are able to increase their walking ability, their discomfort, usually able to sleep better at night, sit in the car longer, watch a movie longer, do those type of things. Get back to low impact activities such as golfing, walking, cross-country skiing, those type of things, low impact. They can usually get back to those. And it does decrease that arthritic bone on bone, that deep ache that brings people in to start with. Like to put a couple jokes in all the time too. There's expectations that people have, kind of like that middle one. I retire on Friday and I haven't saved a dime. Here's your chance to become a legend. Like people have expectations, and that's where you meeting with your doctor to give you a realistic expectation, or talking with other people that have total knees or total hips and figuring out what their experience was with it. Most people are very happy. Also, everybody knows somebody who had a joint done who was back to work 3 days later, because people tend to forget how hard it was. Recovery is difficult. It takes hard work, physical therapy, especially on knees. But people get to that point where they're like, oh, it was great. It was a piece of cake. Kind of like having kids is what I tell people with knees. Most people who have a knee and they're like, I want to get the other one done in 6 weeks. It usually takes them a little bit longer. And they're like, yeah, I do like this knee kid thing and I will have the other one done. But they usually wait a while before they have the second one done. Recovery is tough, hard work. And then we give you good pain pills. Pain pills constipate you, then you have those issues too. So there's a lot going on there. Recovery, this is the other one I like to show too. Recovery is never every day is better. You have good days, you have bad days. As long as you're progressing in the right direction, that's how we expect recovery to go. So again, 1% complication rate, very low complication rate. Why are about 10% of people not completely satisfied with their joint replacement? It's really those expectations. And a lot of it is what people see. Again, you talk to your friends who had joint replacement and they're back doing everything and they've had their recovery time and they're doing well. They don't tell you the little things though. When I do talks, we used to do community talks, and when I ask people, how many of you can kneel on your joint replacement, on your knee replacement? I would say about half of people say they do not like to kneel on a hard surface after a knee replacement. There's no reason you can't. It just doesn't feel good. That scar is on the front of the knee. The knee doesn't feel like it did before. There's a plastic button on the back. But half of people will only kneel on a pad or on a bed or on a couch or something. They won't kneel on a floor again. People have difficulty getting up and down before surgery. They think it's going to help them get up and down after surgery. It doesn't make your joint any stronger. Only work, exercise, physical therapy, strengthening it will make it stronger. It's just a resurfacing. So that doesn't always improve either. So those are the expectations. And then you have those nice guys in the back with the striker stuff, and they send you this brochure showing you you'll be doing yoga on the beach 2 weeks after you're done. So that direct to consumer stuff too doesn't help. So it's a little bit of both. It is a great surgery, has great outcomes. It really improves pain, really improves function. Whether you will be dropping a ski, water skiing again, I don't know, and I kind of doubt. But this is what we see all the time. You read the Reader's Digest and they show these people climbing Mount Everest, whatever, and hiking up miles and miles. It may not happen afterwards. So here's kind of a list of that too, about expectations people expect. That's the last one there is also very interesting. People always say, I can't lose weight with my knee or my hip because it hurts. Hard to exercise, it's hard to walk, it's hard to be active if you have a painful joint. And that makes total sense and is totally understandable, except after you get your joint replaced, it's easier to get to the refrigerator. They did a big study on this and found that people on average gain 5 pounds after joint replacement. That implant is heavy, but it's not 5 pounds. So it came from somewhere besides the implant. think I have a bunch of other studies here. Just with what expectations are and people's outcomes after surgery here. Oh, I gotta go back one. There we go. So there's just a bunch of different studies with it. Kind of the summaries on the side. Satisfaction with your knee replacement, especially hip replacements, are the best surgery we do as orthopedics. People do great. People love those things. They're terribly painful before, and a hip replacement does really well. Knee replacement especially, though, it is a tough joint. The recovery is hard, the therapy is hard, and it's a tough one to get through. Satisfaction, though, the most important predictor is your expectations. What do you expect? If you expect the joint you had when you were 30 or 25, it's not going to happen. If you're expecting to be able to walk unlimited, pain-free on a flat surface, that's very realistic. You should be able to stay on a hiking trail on a smooth surface and go unlimited. You should be able to do all those things. It's just that expectation. A quarter of patients are unable to return to activities after knee replacement that requires a lot of stability of a knee. When we do a knee replacement, a total knee, we either take out the ACL or the ACL and the PCL, depending on how much pathology is in the knee. And that does make your knee not feel as natural as it was. The stability wasn't there. What we do is we compensate for that loss of stability by the shape of the implants. So the implants have a more congruent shape to keep that stability. Doesn't feel as natural as it did before. So these type of activities like badminton and tennis, where you're shifting your weight back and forth and you're depending on that knee stability, doesn't always come to the level you would expect it to. Last thing is with the golf one there, it does raise your handicap on average. It does shorten your drive a little bit. Just the rotation through, it does tend to shorten that a little bit, and the handicap on average goes up almost 5 strokes. Returning to low impact activities is very realistic. Again, getting to the cross-country skiing, the walking on a flat surface, walking unlimited, that's all very realistic. Some people think they can get back to running, maybe jogging, contact sports. I know they had 20 years ago, some football player tried to play with a replaced hip, those type of things. It just doesn't happen. It's not as good as what you had. Heavy manual labor is often difficult to go back to. A lot of times younger guys, though, in their 50s can return to construction type labor, but that knee is sore by the end of the day if you're walking 20, 25,000 steps a day. Kind of the summary part here, get the diagnosis, make sure it's your joint, make sure that's what we're dealing with and why. There's all those non-operative managements. We try all of those first, the anti-inflammatories, the exercise, the weight loss, the injections, all of that stuff. And then people on their own, almost everybody tries something, a knee sleeve, a supplement, or some other type of support for their joint. And then once you do see your doctor and you decide, you know what, let's have my joint replaced, have realistic expectations of that, okay? If your doctor is telling you this is going to be perfect, you're going to be the most happy person in the world, you're going to be running, dancing, jumping, playing football, be a little skeptical. It is a big surgery. The results are very good. You've all met people with joint replacements that are very happy with them, but it's a tough journey to get through it, especially that physical therapy part on knees. Those first 2 weeks are tough. I tell people they're going to suck. First 2 weeks are tough. Then it gets better after that, and we tend to forget the tough part. It's a process to get through it. Best results with any joint replacement or back surgery or any of these, best results are at a year. So you do have to be patient with this as well and allow your body to heal and recover. Okay, I think I have a minute here. I'll answer some questions if you got. Otherwise, the other part is kind of why we're here with that robot and what's going on with that joint replacement and the technology here at Welia. Yes.
So you said the Synvis injection or the Rusier?
Yes. Yep.
That's what the other people normally?
So Synvis injection, that's a brand. I did have a picture of a brand, but it is technically a hyaluronic acid injection. With insurance companies dictating what we can do these days, they all have their preferred brand. They're all the same. They're hyaluronic acid. They're all made in a lab now, so there's no more chickens in them. So allergies are very low, but it's not for younger people. Normally how this goes is when you get the diagnosis of arthritis, we do anti-inflammatories. Then we usually try a cortisone injection. Then if that doesn't work, then we try the gel shot, okay? The gel shot is expensive, usually about $800 a shot. insurance does cover it, but they want pre-approval. So they usually make you jump through a bunch of hoops first. Sometimes doing a month of therapy, failing the cortisone, anti-inflammatories, the rest of that first. There's no age limit on the Syndish or the gel shot. Yes.
How long does it take to recover from these or?
So a year. The best result with a knee replacement is at a year. The first 2 weeks suck. It's stiff, it's sore. We have a great anesthesia team here. They give you a block, they numb up the front of the knee. I put numbing medicine in the back of the knee, so the first day is great. That's why we get you home right away. You're like, they're doing good. Then that wears off. And inevitably, it's at like 2 o'clock in the morning. And then that knee is on fire. It hurts. We give you good pain pills. They make you dizzy. They make you constipated. They can mess with your head, but we give you good pain pills to cover that too. From that, once that block wears off till that 2 week point, it's tough because we want you to bend that knee. We want you to move it. We want you to walk. And you say, my knee hurts. I don't want to walk. And you have to have a good result. The therapy is very important. Having a good result is as much the patient as getting a good knee in there, making sure that you do your exercise. So 2 weeks suck. From 2 to 6 weeks, like, all right, I'm getting better, better, better. At 6 weeks, once everything's all nice and healed up, then you can start taking a warm bath or getting in a hot tub. That type of stuff keeps getting better. Most people go back to work somewhere around that 6 to 8 weeks full time. Best results are at a year. Yes.
Will this replacement also be part of a shoulder situation?
At this point, no.
Okay.
Right now, shoulder replacements are still done with a manual technique on it. They'll tell you they're working on it, but at this point, it's a manual for the shoulder. Shoulders are not as they are a fairly complicated surgery as far as getting everything in there correctly, but the shoulder has so much motion and is a fairly stable joint that you also don't walk on, that shoulders do very well with shoulder replacements. But the robot does not do shoulder replacements at this point. Yes, sir. Most people with hip replacement, again, direct anterior is quicker, but most people are back, even with the right hip, to driving and walking without a walking device by a month. Usually people tell me within a month that it's better than it was before surgery, that deep ache in the hip is gone. However, the muscles on the front of the thigh are sore, the sides are sore. A lot of times people are short. I bring them back up to length. Again, with this robot, I can get you to the nearest millimeter back to length. And then their back gets a little torqued off because they were walking like this, and now they're walking straight, and then that takes a while. So everything kind of works its way out. But usually within a month, people are back to driving. They're not taking anything but maybe Tylenol and feeling significantly better. Yes.
These are the bone going inside.
Yeah, one more time.
You said bones. From the outside or the outside.
Can you set bones from without going in? Not necessarily related to this, but almost every kid who breaks a bone, we almost never do surgery because their bones are covered with a very thick layer that holds it, and we can reduce it from the outside, put it in a cast, plus they heal like weeds, and they heal real quick. Older people, and by older, I mean usually over about 25 or 30, if they break bones, usually it needs to be fixed anatomically, which means perfectly straight. If you can do that with a cast or something, great. Most of the time, we actually have to take the two bone ends, though, put them together perfectly, and put a plate or a rod on them to hold that.
I have a 5-inch plate and 7 screws in my ankle,
Yes.
and then they're gonna take the screws out.
Okay.
Because that weaken the bone, you're gonna have a bunch of holes in your bones.
So she said she's got a plate and 7 screws, and if you take it out, does that weaken the bone? And the answer is absolutely yes, but your body will remodel. So the first 6 weeks after I take a plate and screws out of somebody's ankle, or a rod out of their shin bone, or screws out of a long bone, I do either have them wear a boot or be careful, because just like drilling a hole through a stick, it makes it weaker. After about 6 weeks or so, though, your body remodels that hole, fills it in with tissue, and that weakness is gone. Our bodies are very amazing that way. Okay, one more question, then I'll move on to the next one. Yes, sir, in the back.
You have a knee in and it's
question was, if you revise the knee for one reason or another, do you get shorter? Or does the implant get longer? Or what do we do with that? So revisions are becoming more and more common as people get older. They last longer, the joints last longer, but so do people. And we're doing joint replacements on younger and younger people. On a knee, we balance the ligaments of the knee. So it's a resurfacing of the knee. Your ligaments on the outside that hold you together, your quad tendon attached to your patella, those are all fixed. You can't change the length of your leg through a knee replacement. So the first time, we take as small of a cut as we can with this robot system. Usually it's between somewhere about 3 to 4 to 8 millimeters. Just a little skim off the end of the bone and put a cap over the end of it. Top of the tibia, same thing, a flat cut. Just take as little of the arthritic bone as possible and save as much as we can. If the knee loosens though, or the bone gets resorbed around it, we do have to make up that length somewhere. Either with a thicker piece of plastic, they go by 1 to 2 millimeters, just getting that plastic thicker to tighten up those ligaments, or by adding metal augments to the bone to fill in that space. You do lose bone, and we do have to make it up, because you can't make you shorter through a knee, either through metal or plastic. So those striker reps are going to show you how they work. I got some pictures on my slides on the next one, but they do have some good stuff. Hey, I said one last one.
How do hormone deficiencies affect recovery time?
Okay. So the question was, how do hormones affect the recovery? If you're not balanced with your hormones, growth hormone, testosterone, thyroid, it makes everything harder to heal. A lot of people as they get older have osteoporosis as well. They've got thinner bones. They don't have those bone building hormones. Those all make a difference. As far as recovery, skin moves about the same speed. Whether or not you're healthy, it's just the quality of the healing. The recovery is about the same there. If you have, again, those other hormone deficiencies or renal problems or diabetic problems or something that makes your bones soft as well, we compensate for that by using a different type of implant, usually with some type of a stem on it, and we cement them in place so that it's rock solid. Porous bones and osteoporosis really introduces with the cement, and it gets a very solid fit with a very well-tried history of doing that.
How does that affect that outcome? Longevity of the joint.
Okay, so the second part of that was, how does that affect the outcomes? Once you've healed the joint, it's solid to the bone. If it's cemented or if it's on there, they do last because your body continuously remodels itself and it stays solid. Your risk of something bad happening initially, especially with diabetes and thyroid issues, is higher. Your risk of an infection, your risk of the wound not being strong enough to hold itself together, those type of issues are higher initially, but once it's healed, the results are about the same, longevity-wise. Okay, all right. That answer that? Pretty good? Okay. Okay. On to the next one here.
Is the clicker not working?
It was. It is not working. Oh, there we go. So again, it's very nice to talk here in Mora at Welia Health here. It's a great hospital. It's a great facility. You walk in, everything's nice, new. Your community has put a lot of money into here. Your ORs are state of the art. These robot systems, there's not that many in the state. They're hard to come by. They're expensive. And your community has put a lot of money into making sure that you guys have the latest technology. You would not get a better joint replacement with better technology anywhere else in Minnesota. It's kind of latest stuff, and it's really cool in a small town like this to have all this stuff here. So robotic joint replacement, what can we do with it? Right now, total hip, total knee, and partial knee replacements. Okay, they are working on shoulder stuff and other things like that. But this is where we're at this point with this technology. It's been around for about 12 years, 10, 12 years or so. It's tried and true. They use the implants that they had before, but they can specifically match it to the patient using their technology. So first things first, back to that first discussion. You got to make sure you got the diagnosis. You got to make sure you got realistic expectations. Then we go from there to surgery. So once you talk to your doctor, look at that guy. He's good looking. That was me 10 years ago or 8 years ago. Holy buckets, I'm getting old. So the first thing we do, we've got the diagnosis, we decide joint replacement, we make a 3D model of your knee using a CT scan or a 3D model of your hip using that CT scan and pelvis so that we know exactly what your anatomy looks like in 3 dimensions. Once we get to surgery, then we verify your anatomy with the 3D model, and then the software knows exactly where everything is in space and how that implant will fit you, that we have already figured out what implant, how it's going to be, and how it's going to sit beforehand, and then we fit it to your anatomy during surgery. When we're in surgery, this is where a little bit of fine tuning comes. Usually very little, because again, three-dimensionally, how your bones are shaped, how everything is articulating, and where everything is. And from that 3D model, we have our preoperative plan. So these are kind of slices of the three-dimensional model showing exactly how that implant is going to fit, where the bone spurs are, if you've had prior surgery, if you've got hardware in there, we know where all this is going to be and how it's going to fit around our implant. To get these two together, the CT scan and the model, we have these little trackers. If you look over there, there's a sawbones there. We put those little arrays on. So if you've seen somebody who's had a knee or a hip done here, they have these 2 extra little holes. I usually tell people when they ask, oh, I slipped. Those 2 extra holes are little tiny poke holes that allow us to put pins into the bone so that the software knows exactly where your leg is in space at all times to allow us to make our resection and balancing and leg length perfect to the nearest millimeter or degree. And you can kind of see those over there. Afterwards, those striker reps will be around too. And are you guys going to demonstrate a little bit too? Yeah, show you how it stays in line and how that robot follows it. This tower over here with that array thing on the top, that's watching everything. So this guy here sits in the OR, watches where the robot is, so it knows exactly where the tool is. It knows exactly where the thigh is, or the femur bone, and exactly where the tibia is. And then you put all this together in the software with the CT scan, so it knows exactly how this model is moving in space. So it's very cool if somebody was moving the knee around while you were trying to shape it, the robot would follow it perfectly. And it's very, very quick too. It's very quick to follow it. Okay, so everybody talks about robot knee replacements, robot hip replacements. The real cool part of this stuff is the software part that puts that CT model together with the 3D model that you've made in the OR, marries those together so those implants fit perfectly. So everybody thinks it's robotic knee replacement. The cool part is the software does all that balancing, everything else. What the robot does is make the surgeon so he follows a line and can cut where he planned to cut to start with. So that robotic arm over there, it holds the bone shaping tool in a perfect position. It's still the surgeon that advances it. So that part right there holds either a burr or a saw of some type of bone shaping tool. I physically have to pull the trigger to adjust the speed of the oscillations of the saw, and it does not move forward unless I push it forward, and I choose how fast I want to push it forward. It just holds it on a perfect alignment. So it's not the robot doing it, it's the surgeon doing it with the assistance of that robot holding it perfectly in place. So there's no way that thing could slip and cut your leg off or something crazy like that. It does not move unless I move it. Okay? So this is not the actual robot. In a traditional method of a knee replacement, how we do this is we take alignment during surgery. So we just say, all right, we're going to do surgery. I looked at your x-rays. I got all the implants. I'm going to find something that fits. That's more trays to open, more implants, more stuff on the back table, more implants and equipment, which means more potential points of infection as well because you have more stuff open. With this, we know plus or minus one size, most of the time the exact size. We only have to open one trial, one set of instruments. The amount of hands and stuff open in the OR is significantly less. The less you have, the better, the less risk of contamination. So what we would do is we'd put alignment guides inside of the thigh bone. Makes it difficult if there's hardware or a rod or something else in there as well. So we have to plan that. And then a rod inside or outside of the shin bone as well. If you put a narrow rod down a piece of PVC pipe, you probably can get plus or minus 3 degrees. Because there is some toggle in there. With the robot, by taking the center of the ankle, the 3D model of the knee, and a couple slices through the hip, it's pretty much plus or minus 1 degree every time with very few outliers and more consistent results. Here's a picture kind of what's going on there too as well. The robot is holding that in line with the plane. The advancement is by the surgeon though. Total hip, how do we get from there to there? Without a sex change, because I think that's a woman, but it was a good picture. Same idea on a hip. We do the CT scan. Once you have your diagnosis of arthritis, you failed a non-operative, we get a CT scan of your pelvis and your femur so that we know how you exist in space. From there, this is a traditional one first. So traditionally, this is how we do it. We take X-ray first, and then we overlay a clear template on it. Recently, in the last couple of years, they did do software templating as well. You have a two-dimensional model of a hip or an X-ray. You can't see how far forward or back. You just have this two-dimensional model. You have these little transparent things that you lay over the X-ray to try to guess what size it is. You fit it perfectly to the bone, and you fit how you're going to do it, and you guess how you're going to lengthen the leg and everything else too. So you have a really good plan to start with. You go into surgery, you do your plan. If anything changed anywhere in there, there's no way to see what changed until after you're done with surgery and get an X-ray. Or prior to robotics, what I would do is I would do direct anterior or small hip incision with a C-arm, and I would take X-rays as I go to verify the leg length to offset the implant position. But otherwise, with this plan, the great plan, as long as it fits exactly where you planned it. The other issue with a two-dimensional X-ray is that the beam of X-ray expands as it goes out. If somebody has a bigger butt and lifts them a little closer to the X-ray, your magnification may be off by a little bit. Is that the size or not? You don't know until it's too late or the patient's already in recovery. Okay? With robotic hip replacements, we have a 3D model. Because it's a CT and a spiral CT, measurements are exact. So the size of this pelvis, you can measure any 2 points and you know exactly to the millimeter how big it is. And CTs are actually to fractions of millimeters accurate. So we have a 3D model and we can place our hip, the orientation, the leg length inside the femur bone on the pelvis exactly where we want it. And we know exactly what size it is and we know exactly what it'll be. So we go in with a really good plan. We know what we're going to have, how much we want to lengthen, and everything else. The nice part about the hip is as you're doing it, it is giving you feedback about how far you went. So as you're resecting bone and shaping that pelvis, it's telling you each millimeter that you're going deeper into the pelvis, so that when you get to the point where it's correct, your preoperative plan, the robot says you're there within a millimeter, stop. Or if you want to go a millimeter more, you can if you don't have as good a bone, but it is giving you feedback all the way along, telling you exactly where you are in space. Here's a couple of our preoperative slices to look at again. When I showed you that overlay, when you look at the cup, you see in two-dimensional where you want it to fit. The nice part about the robot and the 3D scan, again, the robot's the last part of it. It's the software part. You can see exactly how that green cup is going to interact with the bone and how it's going to fit in there, not only on that AP view, but on coronal views as well, to make sure that you have good bone to hold that cup and that you've got a good fit. And you know exactly what size too. So again, less trays, you're not reaming up and getting bigger, bigger, bigger until you have a good fit and you know exactly where it's going to go. And the nice software as well tells you how much are you making the leg longer, how much are you offsetting, and where is that implant going to sit. The whole time you got feedback the whole time without the radiation. Same thing I was talking about too. Once you got the CT scan 3D model, I do put a tracker into the pelvis, that iliac crest. So I put 3 pins into there and attach one of those arrays. And that tells the software exactly where your pelvis is. As I'm shaping it, if you move around, if you cough, if you sneeze, if your pelvis rotates, the robot follows it exactly, or the software follows it exactly. I then verify your anatomy during surgery with it so that it marries those two together, your software 3D model with your actual CT 3D model. From there, it knows where you are, leg length offset to the nearest millimeter. So that's the software, that's the cool part. Then the robot finally comes in. This is another attachment for it. That's the reamer thing or bone shaper. It knows exactly where that arm is in space. It knows exactly where that reamer is. It knows exactly the size of it. And as you advance it into the bone to shape it, It's not doing it. I am physically pushing it, pulling the trigger. If I'm not holding those, it does not work on its own. It reshapes the bone. It tells me exactly how far in I'm going. Anterior, posterior, superior, medial, everything gives me all that information real time as I'm doing it. That way you get perfectly placed cups, exactly what you preoperatively told, and it holds the implant, the actual implant, when you put it in as well to verify that it's exactly the orientation you want. With hip replacements, if you don't have that orientation perfect, there's something called a safe zone, which can rotate because we have standing x-rays and then you're laying on the table, your pelvis can rotate. If it's off, the risk for dislocation is higher. So this decreases your risk of dislocation by properly tensioning your soft tissues. We know exactly how long we're making you, and the cup position is perfect every single time. Again, at the very end, with a traditional method, you take an x-ray and recovery, and it looks good. With this, I know exactly where everything is sitting before I put the actual implants in. So we use trial to make sure it's absolutely perfect. I know it's absolutely perfect. There's no surprises later on, like, whoa, that's way further off than I thought it was. So it reduces the risk of outliers. Again, hip replacements have been going on for 50, 60 years now. It's a great surgery. It's just, if you're an outlier, your risk of something bad happening, having a leg too short, having a cup that dislocates is exceedingly less rare when you have all this feedback and information real time as you do the surgery. Total hip results, literally the best surgery you do as orthopedic surgeons. We're extremely happy with hip replacement. Great range of motion. They can get back to doing what they're doing. They can walk in limited distances. Easier to get up and out of a chair. Easier to get in and out of a booth, in and out of a car. A hip replacement is the best surgery we do. And they last a long time. 25 to 30 years, 90% are still going. Great surgery. And that robot just makes it more accurate and more happy. Patients more happy being as they have the perfect hip first time around. Total knee replacement, kind of going to go through all these, kind of how the robot does it. Again, starts out with that CT scan. I'll put that one in there. About 1 million knees a year done in the US. We're right about that number. Last time I looked these up, we were a little over 750,000. We're getting close to 1 million a year in the US. So it's a very common surgery with good results. People are very happy, but you've got to be realistic about it. So traditional knee replacement, again, rods inside the bone. Rods inside the thigh bone and the shin bone, measuring angles off those. We had cutting guides, which were blocks of metal with slots in them that the blade would fit through. There is a little bit of toggle in there as well. You can be off by a couple degrees there as well. And then once we opened up the knee, we had no real idea except from an x-ray of your knee, an AP and lateral, which gives a lot of information, but it doesn't give us all the details. So what we would do then is mark out landmarks. So if you look here, we have our epicondyle. That's typically how the knee rotates around. And if you look at the sawbones, you'll see them where those little ropes are attached to it. But you're looking at these and you're trying to find these marks in a leg that is covered with soft tissues. Some legs are bigger than others, and sometimes these landmarks are hard to find. So you're looking for these landmarks. You're using historically accurate landmarks that tend to be predictive, like Whiteside's line down the middle. You're trying to draw a line down it. And putting all this together, you can get within plus or minus 3 degrees pretty consistently with getting a leg straight and getting it out of bow-legged or knocking. Within plus or minus 3 degrees pretty consistently. With the robot, though, we're talking plus or minus 1 degree for a consistent result every time because you have a CT. You can see the bones. Essentially, the robot is looking at that saw bones. It's not looking at the soft tissue. And we can put that implant exactly where it will rotate perfectly. Again, we do the knee, 3D model from the CT scan, a slice through the hip so it knows where the center of rotation of the hip is, and then a slice through the ankle so it knows where the center of the ankle is. That way we can get you perfectly straight, and we can get you perfectly straight as far as knock-kneed or bow-legged. We get those legs nice and straight, plus or minus 1 degree. Once we have those slices, the software builds that 3D model. We know what size of implant. Again, 90+% of the time, we use the size that we pre-plan. And then we actually go to surgery. So we know what we're going to do before we're in surgery. We know if there's any surprises, cysts in the bone, hardware in the bone. Is it going to interfere with screws that you've had from prior surgery? Plates, do those need to come out? We know all that beforehand, not I may have to do this, I may have to do that, I may whatever, going into surgery to make sure we cover all our bases. Once that's made again, We marry those two together, that CT scan with the actual anatomy of the patient. From there, we can do some fine adjustments of the implants to balance the soft tissues or release soft tissues to allow for that good balance. Is the knee too tight in extension? Is it too tight in flexion? Does it feel loose and wobbly? With that robot, we know before we ever shape your bone, how that implant is going to ride and how the motion of that knee is going to be to give you a more natural feeling knee. We got those over there, the trackers again too. That's how the software knows where you are in space, where the thigh bone is, where the shin bone is. And again, these type of trackers are very, very accurate to the millimeter of where that thing is in space. Here's just some intraoperative pictures of knees as we look at them. Knees that are short of extension, knees that are bow-legged, whatever else too. We can see exactly how many degrees you're off. We can see exactly how much we want to straighten you out to. As we do lots and lots of these, most of the time I don't straighten people out completely. So if you're very bow-legged, 6, 8, 10 degrees, a lot of times I'll just get you like 2 degrees of bears. Because if you've been bow-legged your whole life and all of a sudden your knees are straight, people don't like it. It doesn't feel quite natural. So leaving them within 2 degrees of bears, people are usually happier that way, right? Because it's how you've been walking your whole life. And again, all this information, these implants that are on there, how the knee is going to move and how the gaps are going to be, is all done before anything is done to the bone. There's been no reshaping of the bone, and I know exactly how that knee is going to track with that implant in there. Then finally get to bring in the robot. And the robot, again, not the cool part. The robot keeps that blade perfectly aligned. As I advance it, it makes those cuts as opposed to trying to cut through a metal block that's pinned to a bone with all that play in there. This thing holds it perfect. It knows exactly where your thigh bone and your shin bone are in space, and it holds it there. And it just perfectly lines it up so those resections are perfect. The robot also knows where the tip of the shaping tool is in space so that it won't resect past that. So if you do a smaller incision or cutting under a muscle, I can see exactly where the tip of that saw blade is or that reshaping device is in space without looking at it by watching the screen, watching it advance across the bone. Especially cutting tibias or the top of that. There's lots of soft tissue on the back. There's tendons back there and other things. This robot can really allow us just to come right up to them and stop without damaging those soft tissues. And studies have definitely shown less soft tissue damage while using the robot to do those resections. And here's kind of the picture of the reshaped thigh bone and the top of the tibia there and how that implant fits on there. Again, with that perfect shape of the robot, a lot of the knee replacements we're doing now are called press fit, which means that we can shape that bone. So we got about a 0.5 millimeter interference fit, and that cap will go over the end of it and it will fit tightly. Your body will grow onto it and it'll become part of you. We're 7 after. Are you rushing me? Okay. Yes. All right. I'm hurrying up a little bit here. Benefits of the Mako, again, because you have less outliers, you end up with less issues like needing to do a manipulation or trying to get people more motion. Just because you have more consistent results every time, you're ±1 versus ±3. Pain is less because your incisions don't need to be as big. You don't hurt as many soft tissues because the robot is watching your soft tissues versus trying to expose or stretch things more to get a good view of them. Knee replacement results, again, kind of talked about that in the first presentation there. Knee replacements are great surgeries. 90% of people are extremely satisfied or satisfied. They have a long longevity. Big thing is realistic expectations. Getting to that point where you say, you know what, this is where I'm at. If I don't get this done, I'm going to have to give up these things. And then going back to it. It's never as good as what it was when you're 25 or 30, but it should be a heck of a lot better than what you have. This is the last part of what I want to talk about with the Mako thing is the partial knee replacement. And this is where I really think this software and the robotic system really shine is with partial knee replacement. With the knee replacements and the Mako robot, we can replace the medial, the lateral, or the patellofemoral joint replacement. So if you have a problem with just one compartment, there's no reason always to replace the entire knee. So if you just have pain on the inside, you can replace just the inside. Here's an example of a partial knee replacement, and with the robotic way of doing it, you can do a small incision. The robot is watching the bones, how they are in space. You can't see the whole knee when you do these little incisions in partial. So you're trying to feel through the soft tissue for those bumps, for that alignment. When you do them manually, it's kind of a futzy procedure, trying to get that absolutely perfect when you can't see the whole knee. And the idea of doing a partial is a smaller incision, quicker recovery, quicker back to work. The robot knows exactly how it's going. And these type of x-rays where the implant is perfectly in the middle, exactly like it should be, happens every time. You know exactly how it's going to look before you're done. With the traditional way of doing it, to get this cut right down the middle, right next to the ACL, it's kind of a difficult thing to see. And they're not always perfect how they look. They do very well, but they're not perfect. With the robot, every time looks exactly like you planned. Same thing again, through the hip to get a slice, you know, it's center rotation, 3D model of the knee, and a slice through the ankle. From this, we can put that 3D model on there and plan where to go. So this is where the cool part is that robot makes that green boundary that you see in the corner there, and the robot will only let you stay in that boundary. So I still have to move the robot, which in this case seems kind of dumb because it could do it more efficiently following some type of zigzag pattern or typical milling pattern. But so I have to move it back and forth or up and down until I remove all of that green area. That robot is very stiff and strong, and it won't let me go out of there. So as long as I remove all of the green, when that implant comes in, it fits like a router inlay. Like it just slides perfectly in there. I've mapped the cartilage. It sits exactly to the depth that I want, and it's perfectly flush. And so that's where it really, really shines, where I think that these partial knee replacements do a really, really good job. Literally a router inlay, slides in so nice. Typically, the traditional method, we would use a saw blade. You make flat cuts. It's hard to make it match up with the cartilage. It's very futzy to try to get that to line up. And this is every time, it's perfect router inlay. You've mapped the cartilage, you know where the bone is, slides right in there, and it looks perfect every time. Okay, partial knee again, lateral, medial, patellofemoral. They have great results. 9 out of 10 patients are not using a cane or walking aid at 3 weeks. Less pain because you don't have to flip over the kneecap, do that type of stuff. And they do last 10 to 15 years, not as long as a total, but they do have good longevity, especially if you get them in accurately. Again, the last pitch for Welia Health here. It's a great hospital, lots of good staff. You have a really good anesthesia team that do great blocks, they do great pain control. They take care of you during surgery, take care of you after. They do a very, very good job. These are 4 of our CRNAs and anesthesiologists. Great job. And I don't know how they got a picture of me, but that's me when I get through surgery here in the middle. So hi, working here. And any other questions?
On average, how long does a knee surgery take?
So these surgeries that on average, how long does it take? So hip and knee are about the same. When you think about the surgery, it's going to take you all day to be there. The actual surgery though, from once we start doing the surgery, cutting on the skin, closing the skin is almost always under an hour. By the time you go back, though, you get your block, the anesthesiologist sees you, they get you comfortable, we get you on the table, we wash and prep and clean several times, get everything perfect. Then we all have to get our spacesuits on, get in there, open implants. By the time we're done with all that, it's probably 3 to 4 hours. So it's half a day by the time you're back up again and we get you up in a while. Yes, ma'am.
How long is the robotic been?
When did you guys get one? 4 years. Yep. And I've been doing robotic knee replacement since 2000. Pretty much, yep. Occasionally there are some still done without it. Either insurance doesn't cover a CT scan or something else. So when I do hip replacements without it, I still use a C-arm to do it. I still do minimally invasive if they're a candidate for it. But I use X-ray to verify that leg length and offset. Yes, sir. You can. If somebody has a femoral neck fracture where you would treat it with a replacement, you could use the robot. That does require a CT scan and prepping that. So the reps are great. If the surgeon wants to do that, normally they can get it done, and we get it done within 24 hours yet fixing the hip fracture. When I do hip fractures with for people who fall, I usually just either use the X-ray to do it or just traditional methods. And the sooner you can fix the hip, the sooner you get them moving, the better. So there's good studies that say if you can fix the hip within 24 hours, get them up here and walking, decreases pneumonia, fat source, blood clots, all the bad things. So the sooner the better.
When you break the hip, how do they get that out and replace it?
So So when you get the CT scan, you have a 3D model, and how we do leg length is we compare you to the other side. So if somebody has two bad hips, I do try to lengthen one of them longer than the other, so that when you come back to the other side, I make them both exactly the same. So they compare it to the other side. If it has arthritis, you can make that one a little longer as well. They do have that 3D model of both sides from that one CT scan to get the leg length. Yes.
Do insurance company like pay for the robotic one, or are they more apt to pay for the conventional?
Most of the time they cover the CT, and I would say like 99% of the time, 95% of the time. It's not that much of an added cost because it's a specific protocol for it. It's not read by a radiologist, so it's just kind of just the scan part, and then the reps, whatever else, deal with getting that 3D model and everything made. So it's rare that they don't cover it.
There's
Yes.
overnight stay involved in.
Most, not anymore. So the question was, do people spend the night with joint replacement? Since COVID, people have not, or hospitals have tried to get people out, and there's definitely been a shift in the last 3 years. So prior to COVID, my average stay was about 1.3 to 1.5 days, but it would spend in the hospital, so almost everybody spent the night. And now it's probably 85% go home the same day. Yes.
Who calibrates the robot? Any of the parts that you use affect any of your imaging options?
As far as CT or MRI, it has to be a CT. It has to be the specific protocol. This question was about calibrating the robot. How often does that happen? Every single case we calibrate the robot. And how we do that is there's a special end that goes on that arm that verifies that the end is exactly where it thinks it is. So we recalibrate it every single time that way. Every time you make cuts with the robot, there's also check marks on the handheld device as well as on the patient that you have to verify that nothing has bumped. If the ray has moved or anything else too, you have to be within a millimeter of those checkpoints every single time you make a cut to make sure that nothing is wonky. The scrub person calibrates the first time, and I calibrate between every single cut and verify that it's still active. Yes.
My wife has had 2 knee surgeries now. I told her she can't have any more of that.
The question was, that 2 knee surgeries, can he have any more? I like doing surgeries. Do you want more? Depends on what's wrong with the knee or why it's not working for you or why you need other surgeries.
First one was
Okay?
deep into the bone. The second.
Okay.
But it's still pain.
So if a knee functions, the more surgeries you have, the less likely you are to be happy with the outcome of it, because every time you do surgery, more scar tissue, more loss of muscle, more increased risk of infection. So if it is functioning for you and you can get around and you can do what you need to do, I would say avoid more surgery if at all possible. Again, I don't know the first one, but if it was put in incorrectly or an outlier or something else happened, by doing the robot, those outliers are greatly decreased because we're more consistent at putting them in exactly like we plan every single time. Yes, ma'am. So
After a knee surgery?
the question is, I live on my own, can I go home? A lot of people have knee surgery and go home, or hip surgery and go home. As long as you've got a bathroom, bedroom, kitchen on the same level, most people do just fine. And you got somebody who can check on you and make sure your food and water dish is full. This brings me up to something else too. I think women get married to older guys all the time. They need to switch that around. I have a theory. I tell everybody this. Women should wait till they're 35 and marry a 25-year-old guy. Because when I see 65-year-old women, they're with a 75-year-old guy who doesn't know where he is, and she's ready to travel the world. So. Yeah. I see that. It's not screwed. It's crooked.
It's crooked, right? I wanted to think, look, it's
I don't know what it looks like, but maybe. Okay.
age doesn't make a difference, does it?
Age is a number. It's definitely a physiological thing. There are
I can handle.
Great.
Break it again,
Yeah. Sounds good. Come visit, we'll take a look at it and see if it's good. Worst case, we can cut it off and leave it. I said, worst case, we can cut it off and leave your face on, you can walk on it. Okay. All right, last question over here. All right, you'll do the last one. Go ahead.
Do you do all of your surgeries here or do you?
I am here more 1 day a week, and I work with Dr. Holine as well in St. Cloud, and he's here 2 days a week. So we cover more 3 days a week doing surgeries here. So all the people I see here at Welia Health, I do schedule them for surgery here. And again, the anesthesia team is very good. They can take care of most patients. There are some issues where this hospital isn't big enough. We don't have the cardiology or anything else to do. If you have pacemakers or other heart issues, sometimes we have to do those somewhere else. And then I take those to St. Cloud, but that's very
In
rare.
the St. Cloud, do you do it at the hospital there then?
Correct. Yeah, if you can't have surgery here, it's at the hospital in St. Cloud.
So you don't do pacemaker? I have a pacemaker, so.
It's, each one is individual. I have anesthesia work with you first, but if they say they can't deal with it, or if there's issues with it, I can't do it here. Correct. Well, this is a great town, but cardiology is not something we have here. Okay, last question.
Okay, if you make an appointment with you
Yes.
and you have the x-ray or whatever, do you know what the procedure is when you leave that day? Or is
Yes.
it common?
Yes. Nope, we know what the procedure is. So the question is, with the x-ray in your office visit, would you know what the procedure is? And in general, yes. If you have a specific x-ray where you only have medial joint line arthritis and your deformity is correctable on exam, I would tell you we're planning on doing a partial knee replacement. Yes. There are some deformities that I can't correct with a partial as much as I can with a total, and we talked about that beforehand. So it's very, very rare that that would change or anything else would happen. You know what you're going to get. All right. Well, thank you guys all for coming. Thank you.